to share your experiences and questions. We'll have both a chat function that you can do that, and you're also able to raise your hand virtually, and we can bring people off mute to make comments, to vocalize their comments. Please feel free to introduce yourselves in the chat. I see some folks have already done that. Melanie, Seth, Augustine, thank you for starting us off that way. I hope others will join. So let's go to the next slide, and I'll just show the agenda that we have. We'll have a few introductory remarks. We'll have an overview of social and behavior change in the context of health system strengthening. And then we'll move into the panel discussion. We've got some questions lined up for our 3 excellent panelists, but also please consider the questions again to be questions of all of you too. And we're really hoping to hear from all of you and your experiences. And then we'll move into a wrap up. Next slide. That's me. Next slide. Before we begin and get into our official agenda, I did want to take this opportunity to announce the 2023 USAID Health System Strengthening PACE competition has just launched, and we are accepting submissions of those cases. There's a template that essentially make the cases equivalent to a poster at a conference. Submissions can be entered between May 8th and June 9th. At the link there, and we can put that link in the chat for everyone. So we are accepting submissions promoting health equity and engaging local voices in health system strengthening. Those cases will be judged by an expert panel, and 3 top winners of the case competition will be able to present their work at a global virtual event later this year. So that went very well last year, and we're hoping to have even more cases and new evidence brought forth through that this year. So with that, I will now turn over to 2 colleagues from USAID who will give introductory remarks and help moderate the panel today. We have Rachel Marcus, who's a Senior Health System Strengthening Advisor with the Office of Health Systems, and also Kama Garrison, who's a Social and Behavior Change Advisor in the Office of Health Systems. So I'll turn to Rachel to further introduce herself, and then Kama, and then we'll go into the rest of the event. Thank you.
Thanks, Nathan. I'm happy to be here. We'll just say a couple of things so as not to hold up the panel, and I think you can move ahead in the slides. I'm Rachel Marcus. I'm a Senior HSS Advisor. So we can go to the next slide. Kama, there we go. Okay, so thanks again for joining. We are excited to have everyone here today to talk about this topic. It's an important one. I will dive into it a little bit in a minute, but you can see here just as with the graphic that this is a graphic representing key components of USAID's vision for health system strengthening 2030. We won't dive into all those components today. It's a complicated graphic, but you can see that circled in red are 2 of the key cross-cutting approaches to how we do our health system strengthening work. And one is social and behavior change, and the other is learning and adaptation. And so this event today is a really nice bringing together of both of those key pieces of our work as we think through current states of evidence and learning, and have a nice knowledge exchange related to SBC. Next slide, please. So just a little bit of background. Why are we so interested and invested in learning within our health system strengthening work? We support, as an agency, integrated approaches to strengthening health systems, so that we are able to address systems issues and health needs simultaneously with an eye toward achieving key health systems level outcomes, including equity, quality, and resource optimization. And this really includes a focus on strengthening integrated primary health care as the foundation of the system and to improve all health outcomes, as well as to ensure system adaptability to respond to both health emergencies, as well as long-term pressures like climate change, while still maintaining essential health services. So we think about learning as a key component to both those foundational ongoing components of the system, as well as the system's adaptability and resilience. And within that, HSS monitoring and evaluation, research and learning, shorthanded for MERL, is a critical priority for both of those pieces, the adaptive management and to better understand the long-term impacts of our work. So we are increasingly working to integrate a range of MERL approaches into our programming. Next slide, please. So within the health system strengthening vision and as part of our practice in health systems, we have a learning agenda. The learning agenda goal is to strengthen the global evidence base for health system strengthening and improve our own programming by updating or generating, synthesizing, and disseminating evidence related to key areas of practice. It's organized by 6 learning questions. They're high-level questions, big kind of buckets under which we're working. I won't go into detail there today. They can be found online. But just to say that one of those questions is specifically related to SBC. And so we'll get into that one in more detail today. But our hope in general, as we implement the learning agenda, is that it really does serve as a collaborative platform for continuous learning and adaptation in this space across the broader community. And that's why we have this event today. Next slide, please. So this session is part of the HSS Learning Series. They're roughly monthly, and the goal, as I said earlier, is to bring health system strengthening practitioners together to explore current evidence on key topics, including social and behavior change, like today, to share learning and experience, and to identify some priorities and next steps. So what do we still need to do our work better and to advance the field? And so this is the session for May. And if you go to the next slide, I will turn it over, I think, to Kama for a deeper dive into what we're hoping to discuss today in relation to SBC and HSS and that key piece of our learning work. Thanks so much.
Thanks, Rachel. Sorry about the sun in my eyes. Sun changed in the last 10 minutes. So it's good morning and good afternoon to everyone. I'm Kama Garrison, as I said before. And I just wanted to introduce a little bit about SBC and the health system strengthening so that we're all starting on the same page as we move into the panelist. So today's session has the following objectives: to understand what social and behavior change is and how it might be considered in a health systems context, describe some of the steps that USAID staff partners can take to integrate SBC with health system strengthening, and identify potential challenges to integration. I'll be asking 3 questions of the panelists and give them time to respond, but we also ask that you feel free to put questions, ideas, experiences in the chat, because as Rachel highlighted, this is a collaborative learning event. Next slide. So very quickly, how does the USAID Bureau for Global Health define SBC? Many of you have possibly seen this. Maybe it's new to others. Social behavior change is an approach to programming that applies insights to why people behave the way they do. As Nathan said, our health system is made up of people and how behaviors can change to affect positive outcomes for specific groups of people. And in behavior-centered programming, which is what we refer to often when we're talking about SBC, is behavior-centered program, where we put behavior at the center of our programming. Interventions are designed to empower individuals and collective change. That collective change, I think, is an important point, to create enabling social, physical, and market and policy environments. You can see the official definition here on this slide. I just want to highlight the 3 circles because we want to remember that behavior change is multifactorial. There are many pieces and components to why we change behavior and how behavior changes, and how social change happens, and social norms change. And all of those are really essential for health systems strengthening. So social and behavior change isn't just about information or telling people what to do, but it includes many of the systems components and enabling environment components that are required for us to both change and maintain new behaviors. Next slide, please. I don't want to spend a lot of time on this, but it's a tool that you can find online. It might be referred to by some of the panelists, and it's a way to map out behaviors across both what the priority behaviors we might be thinking of when we're thinking about health system actors, what factors impact those behaviors, which are, as I said, multifactorial, and both supporting actors to support those behaviors, and then strategies. So the strategies aren't just one thing. Often they're a layered approach of many things that contribute to behavior and social change. Next slide. So when we're talking about health system strengthening and SBC, you can say in the chat whether this is a new concept for you, or whether you've thought of this before, or whether you're already working on this. But just quickly, I want to reiterate that health system actors, they all have barriers and facilitators to their behaviors and their decision making. And those individuals and their behaviors impact the performance of the system and the health of communities. SBC supports not just the demand for, I think often we think of SBC in the context of demand creation. So it doesn't only shape demand for accountable or accessible, reliable care, but can support the behaviors of all people, communities, and organizations. When we're talking about HSS and SBC, we're talking about enabling all stakeholders, from clients to policymakers, to practice behaviors that support health. And recognizing there's a bidirectional influence here, with collective practice of these behaviors reinforcing the strength of the health system. And then lastly, but not least at all, gathering social behavior insights from health system actors helps design locally contextualized policies and local solutions, which are successful for behavior change and potentially systems change. And then I think this is my last slide. Next slide. So just a few key points here to leave you with as we move into our panelists. HSS efforts, health system strengthening efforts, should incorporate SBC approaches to address those barriers which influence the behaviors of health system actors. Utilize SBC approaches to increase chances for social change. I think there have been a number of webinars recently I've noticed on SBC and big social issues like corruption. So going from the accumulation of changes at the individual level, we're not only talking about individual level, to transform social norms and structures that influence individual decision making, and transform social norms and structures that influence individual decision making. Sorry, the chat box popped up in front of my slide. And last of all, incorporate behavioral metrics into health systems program monitoring, evaluation, and research. This includes behaviors as a key indicator of health systems program progress and impact. So what we mean here is, we know many of the systems, financing, policy, governance, many of the components we think of when we think of health system strengthening can be also measured by the behaviors in which they impact. So with that, I think that's my last slide. I'll turn it over. We'll start with the panelists. Next slide. So quickly, I just want to introduce, we have 3 panelists today. We have Pierre Balamou, the Deputy Health Office Director at USAID Guinea. Very happy to have him today. We have Andrea Ferran, who is a Social and Behavior Change Senior Technical Advisor at PSI. Welcome, Andrea. And we have Susan Pietrusik, I probably always butcher her name, and I've known her for years, who is a health systems SBC advisor with the Accelerator at ICF. And with that, we'll start with our first question, I think. Is that right? I'm looking at time, so I'm just trying to make sure we move on our time. And as the panelists speak, they might have more to say about themselves and their experience. So question one, panelists. I feel a little bit like a talk show host now. In the work you have been involved in to design programs or implement activities, can you describe an instance where there was a behavior-related challenge that you saw as not being adequately addressed? What lessons did you learn about how to recognize a behavior-related challenge? And I think we will start with Pierre.
Thank you very much, Karma, for this introduction, and thanks everyone for joining this session. And for the question, I think, first of all, we need to notice that health system is a learning system with a large social component, and ourselves understanding the behavior of the actors that interact within that system is crucial to health system strengthening. And I will focus more on the lesson we learned during the 2014 Ebola crisis. We know that at the beginning of the crisis, first of all, it took 4 months before knowing that it was due to Ebola, people was dying, but there were no response measure, and then the government started really communicating badly on the disease, which resulted in the rise of reticence and also reduced trust in the health system on the side of community members. And until we started introducing SBC approaches by implicating or involving community members to design the key behavioral outcome that should be adopted so that people can learn on the disease and adopt a positive behavior such as hand washing, avoidance of handshaking, and safe barrier. That help reduce the incidence case of Ebola, and then the control measure was now going on properly. And as a health system professional, I have learned also that key decision and action in the health sector or health system are influenced by the actors' behavior. The way they think, the way they act, and the way they implement policy and strategy, all those influence the health system performance. We have seen how, for example, strengthening the capacity of healthcare provider to change the health behavior while providing the healthcare service can have a positive impact on healthcare service uptake, because many people have failed or refused to attend maternal health care services because of the behavior of the actors or the healthcare service provider. At the Ministry of Health level, policymakers, the way they think proactively to allocate resources, all those are linked to their behavior, and changing ahead that behavior can significantly improve the performance of the healthcare services. We have also noticed that allocating resources, especially in the health sector, can be problematic. But do the Ministry of Health, for example, or key actor at the Ministry of Health know that allocating resources, that decision goes beyond the health sector, because the Ministry of Health is not the one who allocates resources. And they need to collaborate with Ministry of Finance in order to get the resources to have they want to implement those strategies. Thank you.
Thank you, Pierre. That's a great response. I'll turn it over to Andrea now.
Thanks, Gemma. And I'll build on Pierre's notions around some of the social drivers that drive actors in the system, as well as Gemma, what you mentioned in your slide earlier about using behavior evidence or behavioral outcomes to drive health system examination or analysis and intervention. So I want to focus on two lessons in response to this. The first is a bit more meta and thinking, when you're thinking about equity across an entire population in a country. And perhaps you're seeing that health outcomes are stagnant or there's a significant health disparity for certain groups of people. And from my perspective, this comes up a lot when I look at outcomes like expanding access to services. So in most contexts, a lot of effort has gone into addressing supply side factors like building supply chains, developing policies, task shifting, training providers, refurbishing facilities, delivering last mile outreach, and even generating demand for services. But you'll still see in these contexts that you have large swaths of population that maybe those who live in informal settlements or youth or transgender women whose health outcomes are stagnant or not improving or maybe even declining. And there's usually a behavioral factor driving that. So let's take the case of youth access to contraception. In many contexts, policies exist to enable youth access to contraception. And as Pierre said, national budgets have been allocated for family planning. So there's allocation of budgets at perhaps, national and subnational levels. Providers have been trained in counseling adolescents, and yet adolescents aren't seeking services or they're not being retained in care, right? They're not continuing for follow-up or they're discontinuing their use of contraceptives. And we know that health system actors are products of their social environments. So where you might see this is at the policymaker level when the national budget is allocated and there's a budget line and there's actually funding in the budget, but then the budget is not released. So it's actually not used. So there's a sort of action in the release and mechanism of the funds to actually get them used. In those same contexts, providers might be hesitant to counsel adolescents around contraceptive methods, particularly when they're unmarried or when they haven't yet had a child. And this isn't because of policy or guidance, it's because of social norms and the beliefs that drive the actors within the system. And you can identify where there may be potential behavior challenges when you take a look at your health outcomes and through the lens of health equity or disparities in health service use, which itself is a behavior, particularly when substantial investment has been made on the supply side. And then the second lesson I'd like to share about how to recognize a behavioral challenge is pretty basic. And it's when there are people involved. And so there are many functions within the health system that require people to act and to take action in order for that function to be delivered with quality. So for example, policymakers releasing funding from an allocated budget, or government leaders taking action to govern the health sector, or healthcare workers providing service to clients. Those are all human behaviors. And these require strong systems and processes which enable the actions people must take to deliver those functions. But there's always the human side. And you can always examine that, that aspect and perspective to improve delivery, efficiency, or quality. And the way that I like to recommend this is to get in the shoes of the person who delivers that function, like the provider or the policymaker. You also want to bring consumer or client insights and their consumer perspective or client perspective into your practice, so you can see with evidence and with empathy whether the system is working for the people it's meant to serve. So using the access example, when all the building blocks of access are in place, like accessibility, affordability, quality, are people actually using the services repeatedly over time? What are their pain points? And maybe for chronic conditions like diabetes or HIV that need daily medication and routine care, are people being retained into care, or are they dropping out of service at various points? Really, you know, Kama talked this slide about prioritizing behaviors and doing behavior analysis, but you have to look at the root causes, or whether it's a system or structural factor or an individual or social factor that's driving that. And when the structural access factors are in place, then take a look at what people are actually doing to deliver those functions and to use them.
Great, thanks, Andrea. I appreciate that answer, very comprehensive. And our last panelist, Susan, your perspective on this question?
Sure, thanks so much. You know, in all the comments so far, you know, people have, you know, noted that with SBC, you really have to think about in the health system when their people are involved, you know, then you really want to factor in the behaviors and actions of those people. So sort of building in on that and thinking about, you know, instances where, you know, sort of your way, a certain behavior or way of thinking, something that comes naturally to you, it may not be the case with others. And I think there's often some ways to recognize behavior change challenges and lessons when, you know, things that are just you think as natural, but they may not be. And so in my case, you know, my work, I lead an activity under the Health System Strengthening Accelerator project called Building Better Systems for Health Equity Using Social and Behavior Change. And it's a small activity that we've been working on over the last few years, but it's certainly one with large ambitions in terms of raising awareness and promoting new opportunities for recognizing behavior-related challenges and conceptualizing and refining more behavioral-centered programming. And the activity began with a small study in 2020, and we undertook data collection with some health system stakeholders in Cote d'Ivoire, Ghana, and Guinea. And we used an online survey, and since it's the heart of the pandemic at that time, virtual interviews. And the aim of the study was to consider two prominent practice areas, social behavior change, as well as social accountability, and think about where there's overlap and what synergies can be mobilized from that overlap. And the study in our work since 2020 has been about how social accountability and other health system strengthening work can be more behavior changed focus. So in terms of this specific discussion questions, the lessons I've learned about how to recognize a behavior-related change, you know, I would highlight just a few findings from the study that illuminate the presence of behavior-related challenges in areas that might not be commonly recognized as such. So in various ways through the study, the key informants, they describe that often there is a cultural context associated with social accountability. Perhaps to an extent, a context in which some people feel that accountability is not the cultural norm or culturally accepted. For example, it's not always a given that a citizen will feel they have the right or specific platforms to hold the government or to hold a healthcare provider accountable. This is an example of a behavior-related change that might go unrecognized. To change the cultural context and foster a cultural shift around accountability would need to include behavior change. There is the specificity of saying that behavior change is needed for citizens to embrace holding health sector or government sector officials accountable, while those same health sector or government sector officials must also change their behavior to be willing to embrace citizens holding them accountable. So in addition, there is the broader lesson, which is that changing behavior is the core of what social accountability is striving to do, yet that is not always recognized as such.
Great, thanks, Susan. Three provocative panelists. I think I'm seeing from the chat, I think people's ideas are churning in their head now as they're thinking about the contributions of these two fields to one another. If you have any questions, please put them in the chat. I'm looking at the time so that I make sure we stay on time. And if there are no questions, I think someone already asked in the chat if you had any examples yourself that you have recognized a behavior-related challenge in any of your health systems work that you've had to grapple with. If there's nothing, then we will move on to, let me see, are there any that we want to address? Okay, thanks, Al. Are there any specific questions? Let me scroll through that. We see some great examples. Yes, Nathan, thanks.
I'll just flag one. I don't know, Melanie, if you want to come off mute and say this, but a really great example that you've just put in the chat there. Melanie Yonner.
Oh, hi, that's me. Sorry, do you want me to come? You want me to speak?
Sure, please.
All right. Hi. Hi, everyone. I'm Melanie Yonner. I'm from Save the Children, and I'm really excited that this topic is coming up because it's certainly something that my team is grappling with. So, we designed approaches for first-time mothers in a couple of different contexts by really looking at how those approaches could be situated within existing government platforms for sustainability. So, made some hard decisions and trade-offs to really design approaches that could be institutionalized or that had potential to be institutionalized. And now with some positive findings from our pilot testing in hand, we're working to take those approaches forward and sort of embed them into existing, policies, job descriptions, operating plans, budgets, etc. And in doing so, have really grappled with questions of, with limited time and resources and yet grand visions for institutionalization of these approaches living on beyond our donor-funded project, really what are the behavioral drivers at all levels of the system that would compel someone to take the actions needed to institutionalize these approaches. So for example, we're starting from the health provider level, what the behavior is that we're asking them to implement an approach with fidelity, right? So for example, providing contraceptive services to adolescents, without shame or judgment, et cetera. Moving up in the system, thinking about the behaviors that we're asking for of their supervisors and of higher level managers who, allocate resources and write priorities into policies and guiding documents. And, we're really just grappling with, first articulating what are those specific behaviors that we need people at each level of the health system to take. And then from a project perspective, what are the activities that one would need to plan to actually compel people to take those behaviors? Is it building in lots of site visits so that people build some of those emotional connections to the work and they feel some ownership and they've seen it live in action? Is it, really compelling packaging of the evidence so that people can see, yes, this has shown impact and it's shown to be acceptable for implementation. So I will stop there, but just to say those are all the questions that my team is grappling with, and so I'm excited that these conversations are happening. Thank you.
Great, thanks so much. Oh, and I realized I wasn't muted. Sorry if I was breathing heavy. We have one more question, and we'll move on to the next panelist. And thank you, Melanie, for that. That example is very, very helpful. We have a question from Kathy Stephen about do any of the panelists have experience using SBC to identify and strengthen disability inclusive behaviors or reduce disability stigma in the health system? I don't know if there's anybody jumping to take that question, but maybe I ask Andrea if she has any thoughts first.
Yeah, and thanks for that question, Kathy. I don't have experience specifically addressing outcomes of improving disability inclusive behaviors like within the system or reducing stigma within the system. However, I have in many programs and recently in a design for a sanitation award in Liberia have worked to ensure that the co-creation from the conceptualization as well as the strategy for SBC and market development for sanitation products and services are co-designed and validated with the sort of national leadership, the Commission on People with Disabilities, in collaboration with the Ministry of Internal Affairs, the Ministry of Health, and the sanitation governance folks. And so, you know, part of that is ensuring that there is at the strategy development and operational planning that, you know, there's appropriate co-creation and segmentation for various populations that include the authority on disability inclusive programming within that country, so that you can build within the social movements as well as support continued connection across the various sort of functions. That's less kind of operational in terms of really achieving the outcomes that you've asked about in your question. But you know, I think as a minimum best practice, ensuring that in any design and in any programming that will address service availability, product availability, or behavior, that the authority and Commission on People with Disabilities in that context and people living with disabilities themselves are involved in the co-development at not just the intervention level, but the strategy and sort of the operation level as well.
Thanks, Andrea. And I see with time, I need to move on to the next question. And if any of our panelists have any other further thoughts, maybe at the end, we can come back to that. Question 2, in instances where a behavior-related challenge has been identified, what do you see as the process to move from identification to designing and implementing an action or activity? What are some of the specific strategies and tools that can be used to apply a behavior change lens? And with that one, we start, I think, with Andrea.
Wonderful. This is a great question, Kama. And, you know, I think the good thing is that we're not starting from scratch. You know, I think that there's some limited evidence and there's some really strong questions in the learning agenda around how do we apply theory and evidence from social and behavior change practice at the individual and provider level higher up in the health system. But we're not starting from scratch. There's many theories and there's a lot of evidence that we can use to hypothesize what might be applied in the context of health systems, and also draw on some of the economics-based approaches that have been used for decades to support and improve behaviors within the health system. I think the first key is really to understand and identify the issue from both the systems as well as the behavior perspective. You know, you want to look at any possible factors and really define the root causes, determine the structural and systems interventions, and then the key behaviors that need to be addressed in order to achieve your outcome, your system's outcome. And Kama had shown a slide in the beginning. There's a really useful set of tools that USAID invested in a number of years ago to support identifying root causes and identifying and prioritizing the key behaviors that drive them. And I think we can put the Think Big behavior integration guidance tools around focusing and prioritizing on behaviors in the chat so that folks can draw from those tools. A couple of key points, you know, just to keep in mind when applying a behavior change lens. First is always have a specific behavior outcome in mind. The second is to ground your design in theory and evidence so that you can understand the logic and the causal pathway of the interventions and the factors that can shift that desired behavior. The third is to focus on a subset of the population of people within your system and learn as much as you can about them. And then finally, you want to build in adaptation points and learning along the way. And I want to bring this to life with an example because, you know, it's easy to say like, here's the best practices, but I want to share an example of how one of my teams did this in PSI in Laos. So they used a behavior change lens to examine health insurance use. And the team is supporting the government to assess and understand the drivers of low use of the National Health Insurance Scheme. So in 2016, Laos government rolled out National Health Insurance Scheme that can be used at public sector facilities. And it was great. It integrated already existing social protection mechanisms. It dramatically expanded health coverage, and it drove an increase in public health service utilization where there is a thriving private sector market. So access to health coverage was widely expanded initially as people bought into the national health insurance, but then the actual use of the insurance was low. So sort of attainment of it was high, but then use was low. So if you looked at the statistics, about half of outpatient care was covered with national health insurance, and only like 5 or 6% of inpatient care was covered with the insurance. And so we had a behavioral challenge. And then the team used a behavior lens to understand why people had insurance but weren't using it. And so we used a tool called journey mapping, which is a tool that's been used, it's from design thinking, but it's been used in practice for a number of years to map out patient or provider journeys through healthcare settings or, you know, a care cascade. And the journey mapping tool was applied to 2 segments of populations, people who use health insurance and people who didn't. And they found important insights. So first was that the 2 primary drivers for use, which divided the population, were the cost of care and convenience of care. So people had very different, and you could divide the segments into 2 populations of people for who cost was the most important factor, and for people who convenience was the most important factor. And for most people who didn't use, their discontinuation was a deliberate choice based on convenience. The second insight was related to emergency situations. So when there was a health emergency, families didn't have time to get or access their insurance book, so they couldn't use the coverage. And remember, like the inpatient care, which is what you would need for emergency, was very low, like 5 or 6%. So that logistical hurdle of having to carry the book with you or get the book in an emergency was an issue. And then finally, and this is really telling, people lose access for periods when they move. And people are migrant in many contexts, but this was really apparent among young women who moved to a new village to live with their husbands after marriage. And they had difficulty registering in the new book, which limited their ability to get affordable care through national health insurance when they became pregnant early in their marriage. And so this is just an example of how we used the SBC tool of journey mapping to really look at not only the structural factors, but really people's experience and what was driving the behavior of not actually using the health insurance. And then we could solve for those problems.
Thanks so much, Andrea. Great answer. And I see some great comments in the chat that we'll come back to. Our next speaker is it's Susan, right? Yeah, Susan. Sorry, getting lost in all my papers.
So yeah, I wanted just to again to draw on the this 2020 study that I mentioned before on the linkages, improving the linkages between social accountability and social behavior change. And with that research, it really drew attention to the ways social accountability activities and efforts to advance UHC overlap. And they share the aim of a more socially conscious health system whose functioning revolves around inclusion and accountability for actions. So in considering that overlap further, we put that in the context of some of the data from the study, and it sort of revealed that efforts to advance UHC often tend to be top-down. And there are few pathways for involving citizens in UHC efforts. And sometimes UHC efforts have limited representation from diverse groups. So following the study, we were able to sort of bear these findings in mind. And what we did was we designed and we held an SBC workshop for the Togolese UHC task force and invited as well selected CSOs. And so the goal of the workshop was to discuss barriers around implementing the UHC roadmap and how behaviors of specific actors were increasing or decreasing those barriers. So again, sort of the specific tool and sort of the step that we took was a behavior mapping exercise. And so given the workshop was with a UHC task force, we have also applied a health equity lens in the sense that one end goal of UHC, which is a pursuit of equity, is for individuals to have fair and consistent access to health services. For this to be realized means that there must also be work to ensure individuals have the option for a seat at the engagement table when decisions around what constitutes access and what constitutes health services are made. In deciding the workshop, we included CSOs that work with specific population groups, such as people with disabilities, people living with HIV, adolescent girls, women, children, rural populations. And we tried to think about how health equity cannot simply be a top-down proclamation. It must be built up, ensuring that the build-up requires representativeness. And so a key output of the workshop series was a list of action items that consider the different actors and related behavioral perspectives. Here we were seeking to help the workshop participants increase their understanding of how behavior change might be needed across government, health system, and citizen actors to help advance UHC. Also, the workshop fostered thinking and discussion in terms of entry points for involvement and advocacy. This includes recognizing the different but overlapping roles of citizens and citizen organizations. To advocate and be involved means opening a closed door or stepping through an already open door, and doing so with a specific advocacy strategy. Behavior change comes into play here because sometimes efforts cast as advocacy involvement have limits and can fall short without complementary focus on the potential need to change individual level and institutional level behaviors across a broadly cast range of health system actors. In the end, and in sum, UHC advancement is a site where behavior change is required. An important strategy and tool that can be used to apply a behavior change lens is convening people to map what behaviors need to change and what behaviors from what actors need to change.
Great, thanks, Susan. And Pierre, your thoughts on this question?
Yes, thank you very much. And I would like to echo Andrea. People really need to understand before change. And this is why defining the behavioral outcome is very important in promoting behavioral change or adoption of positive behavior. We have seen how the use of role modeling, for example, have improved providers' ability to provide good care, and also tend to replace the traditional classroom training. For example, during the implementation of our health service delivery project, we know that the healthcare providers are constantly rotating. So, and having the new staff, for example, trained through a traditional classroom can be challenging, but role modeling has helped to improve the ability of new staff or new healthcare provider to be able to provide good care to citizens. And also, we have the use of incentive, for example, the recognition of as incentive have had an impact on improving the facility manager ability to conduct self-assessment and also to be able to succeed or to meet defined criteria with the Minister of Health or with local community. And when we see in terms of policy aspect, for example, we truly know that no matter how well a policy is developed, it cannot implement itself. And the success in implementing in any policy is related to the actor's behavior that take the initiative to implement the policy, or that take the initiative to adapt the policy throughout the implementation. Many years ago, the global community have committed to the health for us, for all, and even the process of ensuring the universal health care coverage, we truly know that we are still far from meeting the goal. And no country in the world have succeeded in making the healthcare at least closer to a public good. We are still far from there, and we will never get there unless we change ourselves, unless we change the way we define policy, unless we change the way we develop policy, unless we change ourselves in terms of allocating resources and also providing care to citizens and also monitoring and evaluating our practices. Thank you.
Thank you, Pierre. Great comments. I'm looking at time. Do we have any questions specific to this question? I see some questions in the chat that I'm going to come back to after our third question, but anything specifically related to this question, or share any experiences you may have. Some great comments in the chat. All right, with that, I think I'm going to move on to the last question and come back to some questions so we make sure we cover our 3 questions. So next slide, please. And question 3. Often behavior change focuses on an individual's behavior and is aligned with a specific health condition. Recently, there's been increasing attention on the behaviors of a broader range of actors within the health system. For example, a focus on government, health facility, and citizen actors must change their behaviors as part of working to address the need for health systems change. What are your views about this shift, and why is it important? And we will start with Susan.
Thanks, Kama. You're doing a great job as our moderator. I really appreciate being part of something like this.
There's a lot of things popping around.
Yeah. I feel like we should have a little bit of that, like on the talk shows, have some, walk-on music and things to narrate us. In any event, yeah, for me, this question, for me, I feel like I've been in the thick of this shift for a few years now. And it's really something I found quite interesting and really required me to think in a lot of new ways and sort of learn new ways of thinking, and it seems to me that there's a lot of momentum that is increasing and a lot of interest in, having a session like this and the number of people that are, interested in this topic. So I think that's really great. And it seems a little bit even that the momentum and, is somewhat indirect. And so by that, I mean that more and more people, take a systems perspective and sort of our systems thinking, and they may not even realize it, sort of just doing it without, consciously thinking about it. And so, once you place your interest and focus on understanding context, and looking at what's complicated and why something is complicated. This is part of wanting to factor in how systems work or don't work. And if you're recognizing that people live in certain surroundings and contexts, that there are many nuances to these specific contexts, and you try to understand what people do and don't do and why or why not, that's all systems thinking. And if you take this type of perspective, sort of a systems thinking perspective, it's not a big leap to also focus on specific actions and behaviors of actors within the context of a system, say a health system. And so broadly speaking, health system strengthening has a wide range of sort of programming examples, whether it be, social accountability, I spoke about, and Andrea mentioned some health financing and health insurance types of programming, health governance, health system resilience, certainly the Ebola crisis and the lessons that were learned from that Pierre spoke about, the advancement of UHC. So a wide range of ways that health system strengthening program, unfolds. And, they share the common goal that they want to bring about positive change at the facility, the system, and policy levels. And so, across all of these areas, and just in the idea of health system strengthening, the link of systems thinking and integrating SBC approaches can open space for important insights and improve programming. Indeed, behavior change is relevant to any international development endeavor. This is to say that fundamentally, pretty much every development goal or activity requires that someone or some set of people change their behavior. And so just sort of in sum with this question, I would say that in terms of systems thinking, as well as health system strengthening and social behavior change, that these are kind of big umbrella terms, and that each serves as sort of a gatekeeper for a wide range of activities, approaches, interventions, strategies, tools, and across that type of variety and nuance, there is no singular way to be a systems thinker, or there's no singular way to apply a behavior change lens. Trying to pinpoint a one-size-fits-all strategy would risk oversimplifying and generalizing specific economic, geopolitical, sociocultural details and context. Instead, applying a systems lens and as relevant a behavior change lens must be tailored to a specific context, which requires a fair amount of research and thinking and engagement, where the effort is to sort of map and unpack complex dynamics and look at specific actions and behaviors of key actors and help establish whose behavior needs to change, and sort of thinking through a strategy of how to do that. So to me, I think, this is a really exciting time, and with these ideas and the growing number of people that are involved, and I think it's a shift that's very manageable in the ways just for people to start to think about these interconnections and new and important ways. Thanks.
Great. Thanks, Susan. Andrea, I believe you are our next panelist to speak to this.
Thanks. I agree wholeheartedly with Susan. I think the systems perspective is really important when thinking about collective behavior. And oftentimes system thinking focuses on maybe structures and systems and the interrelationship between nodes or components of the system. And for me, really, when I think about the essence of a system, it requires many, many people to act in a coordinated fashion. And I want to give an example of this and governance of the private sector, which I know is a private sector engagement, as well as governance and oversight of all sectors within the health system is a really important priority in many countries and for many ministries of health. So in many contexts, there's a goal not only to really engage or regulate, but to truly govern a high functioning mixed health system, including public, private, and self-care options. And the WHO has done some really interesting work through its advisory group on the governance of the private sector for universal health coverage. So, they're organized around the goal of universal health coverage or the vision, and, have an advisory group on governance of the private sector. And they published a framework, and we'll put it in the chat, a framework and a technical brief on strengthening government inclusive health policy to respond to the growth in scope and the role of the private sector in health. And the framework is organized around behaviors. It's organized around 6 key governance behaviors that are required in order for the public sector to effectively engage and govern private sector. And, just stepping back, I think when we think about governance, we usually lead with coordinating bodies, like mandates, quality standards, coordinating bodies. And those are important, but once those are in place, I really encourage you to focus then on building up the practice of key behaviors of the bodies within the public sector that have the mandate to engage the private sector in order to truly expand and shape a high quality mixed health system. So we'll put the link in the chat, but the 6 governance behaviors are deliver strategy, align structures, enable stakeholders, build understanding, foster relations, and nurture trust. And on that final point of trust, we've all seen with COVID how important both client, individual, as well as provider and health system actor trust in the health system is in terms of delivering and ensuring practice of evidence-based response to pandemics and practicing new behaviors. But it's also critical within the health system to nurture trust and actually sort of act and facilitate trust across sectors and across bodies and units within the health system. So I'd love, as we continue, for both systems and behavior experts to bring our heads together and solve for some of the situations where behavior might be a driving factor in delivering against a systems change.
Thanks, Andrea. And I think I put the right link in, so you can maybe double check my links. And our last panelist to round out this question is Pierre. Over to you.
Yeah, thank you, Andrea and Susan, for pointing that out. System thinking perspective is very important, especially health system always face the out of sight, out of mind syndrome. And it is very important to bring in various perspectives from various sectors so that the response or the thinking can be faster and the response can be very coordinated. We have, through our Global Health Security Program, working with the Ministry of Health, Ministry of Agriculture, and Ministry of Livestock through the One Health platform. We have strengthened the ability of the government of Guinea to prevent, detect, and response to outbreak. If, for example, the 2040 epidemic, Ebola outbreak, took 4 months to be identified, Guinea has been able to identify yellow fever outbreak within less than 72 hours. So that is really a great learning and a great success in terms of building the ability of local capacity to respond through a multi-sectoral perspective. And through our accelerator process, we have also learned how engaging the government actors, civil society, and donors and partners through a co-creation process have helped to improve the understanding of role and responsibility in the implementation of the Guinea's new community health policy, and which has helped a lot in terms of ensuring the accountability of actors involved in the process. And the project was able to build the capacity of local entities, civil society organizations that have been able to conduct several advocacy meetings with the Minister of Health, Minister of Finance, Minister of Budget, and which resulted in the government to pass a new law that includes the salary of community health workers into the government payroll system. Thank you.
Great, thanks, Pierre. Some really great points were made. Are there any specific questions specific to this question before we go back through the chat and address some of the other comments and questions that have come up? Let's see if I see anything. I guess I would maybe ask the audience also, you can put in the chat if you tried to implement SBC in your health system strengthening work, what do you think would be your greatest challenge? And what kind of skills or information would you need? And you can put that in the chat, or you can come off mute. And if nothing, then we will start to go back to some of the questions. We had, thanks for the slide. I keep forgetting there's a in-between slide. So we had a question earlier on from Nina. I don't know if Nina is still on, around healthcare providers. A question that's near and dear to my heart. The question is, one thing we are seeing across the HIV response is that healthcare providers themselves are experiencing a lot of strain and stress as the same strains and stresses that their patients are. As we try to shift provider behaviors to address issues like stigma in HIV treatment and prevention, we're seeing that we need to start with providers' emotional and social challenges. So I don't know if anyone of our panelists want to comment on that. I know I can say from USAID's standpoint, across all of our health programs, we are focusing more on the experience of that provider, because that provider exists in the same social context as the clients, patients, and consumers that they live with. And we have not paid enough attention to their own emotional and social challenges. And we expect superhero outcomes from them. And so how do we address the social and cultural context in which they're working in, which they're living in, that impact the way they provide quality services? Do others want to speak to this?
Yeah, I can build very briefly, Kama, and a bit on what Nina shared. Is there's been a fair amount of work, or a growing area of work, in using empathy, or really sort of stepping in the shoes of clients. And I think that empathy lens and really stepping in the shoes of providers is the next wave of how we'll use empathy and sort of the experience, the emotional, social factors and drivers of providers, not only just to provide better services, but to make their conditions and environments more conducive to provider well-being as well as their productivity. So, I think that, just to echo, I think this is something that we'll see more of in using empathy-based approaches with providers, not just delivering them to providers so that they have better empathy, but actually empathizing with and better designing and adapting health systems for providers to thrive as well.
Great, thanks, Andrea. Anyone else, Susan or Pierre, want to comment on that?
Sure, I had just one thought that sort of come to mind. I mean, certainly I think it's really interesting and important, that there is a shift in this focus on provider behavior change, and seeing that more and more. And I think that's a good shift in what Kama and Andrea, what you have said, really, I think, it's important ways to think about it. But also sort of comes to mind that once you introduce the idea of provider behavior change, I think it's important too, because it's a little bit of a gateway to like who the provider works with. That provider works in a facility. There's a manager above that provider, a leader of a health facility who is responsible to a party in the government, and so that sort of chain of command, I think it sort of opens the door to look at all of those actors, which I think is an important shift, where, I think historically so much attention is really, in the case of this example, the question that asked would really only have been on the behavior of the person living with HIV. And now we're shifting to look at the provider and who else is in that provider's world, their supervisor, their boss, people they work with, their relationship with the government. So I think it really helps to look at the whole context.
Yeah, great, thanks. Any additional comments? Otherwise, I'll move on to another question. Let's see here.
Kama, just one more note on that, and building, Susan, on what you shared, I think the other important thing to remember is that practice of behaviors of any actor, as well as the factors that drive them, are dynamic, right? It's not like you change it and it's forever changed. In some cases, that's true, but what's really important is making sure that you have metrics that can track the factors that influence behavior of various people within various actors or bodies within systems, as well as sort of the ultimate use or delivery of those, which frankly can often be challenged. There's really strong health management information systems related to sort of your ultimate outcomes of behavior, of service use, of product uptake, of continuation and discontinuation, but far less available evidence that's systematically generated or shared on the factors that are driving these things. And so it's important to consider that in measurement plans, in your hypothesis of programming, but in collaboration with governments in terms of taking the next step in making routine monitoring data available that can show you some of the dynamism, or so that you can respond when things and adapt quickly.
Great, thanks, Andrea. I see a question. Excuse me if I say your name incorrectly. Akanam. Around, I find that from a measurement or theory of change perspective, change in knowledge and capacity is easier to note, but change in behavior is dependent on maturity and quality time that needs to elapse in order to see behavior change. So behavior change takes time. Have the panelists and or others grappled with this? Anyone want to jump in on this one?
Karma, can you reframe the question, please?
Yes, here, I'm going to cut and paste it back into the chat because it's up a little bit further. And put it in the chat. So I believe the question is that behavior change takes time. And I think we're talking about a lot of different actors in the health system. And so how do we grapple with, or how do we address the time behavior change may take? Do we have ideas? What are things that can be done, short term, medium term, long term? How do we think about behavior change? Maybe not the change that has to happen that may take 5-10 years, especially when we're talking about social change, but how do we think about behavior in sort of these different stages? Maybe that's a way. I hope I represented that correctly. It's a very difficult question.
Yeah. Yes, it is a difficult question, but I think, as Susan says, understanding the context is really important, so that you can define the stage of change gradually, because as the question said, or it is in a reality, change takes time, and it is important to have like a milestone. When we refer to the trans-theoretical model, which specify how change can happen from like the precondition aspects, by being aware the person is not even aware of the situation. By bringing the person being aware and adapting positive behavior can be like a stage approach that the person can learn throughout the approach. And the incentive aspect is very important when the person step from the low stage to the level stage, so that the person know that they are doing the progress. Let's refer back to the provider behavior, for example. And in Guinea or in West Africa, I think in 2019, WHO conducted a study that showed high level of mistreatment of women during childbirth, for example, which is very concerning. And if you want to tackle that approach by helping to improve provider behavior, but you need to understand the context in which they are working. Maybe they are not several midwives in the hospital, and they are working so longer with low wages. Maybe there is no incentive system that can help them a little bit improve their economical condition so that they can be happy when provided. So these should be defined, clearly defined, and stages in the manner that provider can navigate throughout the process while learning and also seeing the impact of the change in the behavior.
Yeah,
Thanks,
I would,
Pierre.
Susan, go ahead.
Sure. Yeah, thanks. I just I was thinking about this, and I think the UHC is sort of a great avenue to sort of look at the way that the parallel to when a country is pursuing UHC, there's sort of a parallel way that behaviors are changing. You know, pursuing UHC is something that takes time, and it's fundamentally, it's a pursuit that is about increasing inclusion and equity and giving people greater access. And to do that, you know, each step of the way in a UHC roadmap, you know, they have to change the way they think about healthcare. And then each step of the way in UHC, if there are different, you know, sort of policies or programs that help to, you know, to advance UHC, that is requiring individual people to fundamentally change how they access healthcare. So their behavior has to change too. So I think that those two, you know, those pursuits, you can sort of, it would be interesting to, you know, over the course of 5 years, kind of look at that in parallel, what an effort to advance UHC and what in tandem, what types of behaviors have changed.
Yeah, and just one more tip from a practical sense. Ekpenyang, you're right. It can be difficult to measure and also can take time to see changes in behaviors. And, you know, I shared earlier, what's really important is to focus in on a very specific behavior and among a very specific audience, as well as really contextualize the factors that you're addressing and ensure that you're measuring the intermediate outcomes or those factors that you believe are going to address behavior. And the reason I'm re-emphasizing this is because a lot of times some of the measurement is done in like knowledge, attitudes, and practice, right? Which really lends to what you've said about changes in knowledge, changes in skills, changes in capacity, maybe some attitudes, but oftentimes those surveys or those you know, measurement of those factors isn't tailored specifically to what where your program is intervening in very specific factors for provider performance, say. And so really, you know, focus and prioritize both your design as well as your measurement, and you'll be able to establish your theory of change more clearly, but also measure it along the way and save resources by not measuring a bunch of other stuff that you're not actually addressing. It sounds obvious, but this is like in behavior practice, these things are not like always aligned, because there's kind of standard tools for how folks scan and understand over time knowledge, attitudes, and practices, but those aren't necessarily updated with the new information or sort of the new interventions that we're doing.
Great, thanks, Andrea. We had a comment or a question for Augustine. I don't know if Augustine is still on the line. I saw your question and now I'm looking for it. Is it the one around, Elle, I don't know if you have it. Sorry, I'm scrolling through. Or if Nathan.
I just
saw it.
I just repasted it in the chat.
Oh, great.
And Augustin, je ne sais pas si vous êtes toujours là. Vous êtes coach de psychosocial coach du Cameroun. Vous êtes là? If you're there, feel free to speak that question in English or French. Not sure if he's still on.
He's still on, but maybe I'll read the question and unless he's coming off. So just like patients, health professionals are subject to enormous stress, both in the follow-up of patients, especially HIV, which requires discretion, and also notions to avoid stigmatization and discrimination to which patients are subject to. I think it would be wise to start with staff in order to build on their skills in this task. Yes, sorry, that's a dog. Great comment and question, great comment, I should say, around starting with staff. And I think there's clearly interest in addressing the provider side in SBC. I don't know if anyone wants to comment directly on that, or Nathan, if you or anyone wants to comment in French for our Francophone colleagues on here. I did see someone ask if there are French subtitles, and I apologize, there were not. Any comment on Augustine's comment? It was a great comment. Starting with staff.
Yeah, I agree. I think starting with staff and ensuring that when we are creating welcoming, inclusive environments and also addressing stigma, we are starting with all the staff at the facility. So not only providers and supervisors are important, but there are so many staff, including the guards at the gate and the people who sort of walk you through the entryway. There's many people, depending on the level of facility, who are there. So ensuring that there is appropriate attention to addressing stigma and making sure that, you know, a lot of what we talk about is the evidence of how certain factors lead to behavior change, but there's really strong evidence of what interventions lead to that. And so addressing stigma, like you can't just do a training, you know, a sort of learning knowledge-based training to change stigma or attitudes or bias, right? There needs to be values clarification, and addressing attitudes. Typically it requires dialogue and sometimes empathy, and then as well as supervision of how you enact and ensure you're providing services that are not stigmatizing. So I just agree with you and building on that more. Thanks for the reminder though. It's stigma and addressing attitudes, as well as how stigma and discrimination are perpetrated within systems, is critical.
Great, thanks, Andrea. I think we will begin to wrap this up. I want to thank everyone. I think there were some really nice themes that came through in this webinar. A lot of interest around, I think, different actors in the health system, how we get started, tools we can use to address some of our other audiences other than clients, patients, and consumers. We will put some of these, I believe some of these tools we can put in the email that goes out to you with the recording. Some of the patient pathways, journey mapping, empathy mapping. I will also say one of the questions around stigma that I think many healthcare systems are grappling with, and I know even in the US, this has been a question that's that we're trying to answer, is as you change parts of the system, even if the person internally may still not quite have changed their own biases, this system can shape the way they provide services in a way that minimize that bias and discrimination. And so I think this reinforcing piece of social behavior change contribution to health system strengthening, but also health system strengthening to social and behavior change is really important. And as we gather more evidence in that bidirectional relationship, we will probably continue to have this conversation with you all. With that, I want to just do one reminder. I believe the next slide. Let's see, yes. A reminder that, and you will get these links, that there is an evidence gap map that USAID is funding that is a snapshot of the state of the art, and it has 4 of our 6 learning questions mapped so far, and 2 more are coming, including SBC and health system strengthening. This is, an opportunity to identify gaps in the evidence and design ways to get evidence to address those gaps. And then, as Nathan said in the beginning, don't forget to submit your ideas for the case competition. And with that, I want to thank our panelists. Here's some resources. These will come to you through your email. I want to thank our panelists, Susan, Andrea, and Pierre, for their engaging ideas and thoughts. And I want to really, really thank the audience for your questions, your examples, the tools you suggested. And I hope this webinar has challenged your thinking a little bit. And I hope we continue to have future conversations. With that, if there's no other comments, we will close this session out. Thanks, everyone.
Thanks, everyone.
Thank
Nice
you
to
all.
talk to you today.
Thank you all, and we will be compiling some of the